Good evening, everyone, and welcome to the April meeting of the Academy of Integrative Health and Medicine's Cleveland chapter. I'm Peter Geller, co-leader of the chapter, and also with us tonight is Jessica Price of the AIHM. She is the executive director of our org as well as the associate fellowship director. Well, we are really excited to be presenting tonight's webinar on Psycho-Oncology, cultivating an anti-cancer mindset through emotional resilience, stress management, and mental well-being, presented by Brandon LaGreca, licensed acupuncturist. In keeping with our recent policy of trying to extend our reach into realms that we haven't delved into before, or subjects that we have done, but this is maybe less familiar to many people in our community, or things that we've done before that are rather well-worn topics, but from a completely different angle or different emphasis. And I think tonight's webinar probably fits into that last category, because if you've been following our schedules at all, you know that we have done many webinars over the last few years on integrative oncology, but we have never done anything that targeted the emotional, mental, and spiritual aspects of the disease in this intensive fashion. So that's what we're really excited about. And a brief intro about Brandon. Brandon is an author, an integrative clinician, and a 10-year stage 4 cancer survivor who navigated his way back to health by employing the methods that he developed along the way. So he's going to tell us a little bit about his journey, and then he's going to go into research about stress and trauma and how it affects the physical body and so on. A lot more things in that department. And then he's going to give us also a few tips or hints about how we can all try to maintain our balance and emotional resilience through some simple exercises. Actually, I don't know exactly what you have in mind, Brandon, but I'm sure it's going to be great. So before I hand the floor over, I would just like to say one other thing, two other things. One is that please, if you have any questions, don't hesitate to put them into the Q&A. We're going to go with Q&A tonight. And if you do have comments as opposed to questions, feel free to put them in the chat, and I'll try to monitor them before the end of the meeting. And if anything calls for a comment or something that I think Brandon would like to see, then we'll handle it that way. But for straight questions, just put them in the Q&A for now. And finally, I'm going to hand it over to Jess for a second, because she has an announcement about another webinar, or another seminar, I should say, that she's going to tell us about.
Yes, thanks, Peter. Let me just quickly share my screen. So great to see so many people here this evening for such an important topic. I'm excited to learn more. And I'm just excited also to share the AIHM is going to be partnering with the American Academy of Family Physicians at their Family Medicine Experience event in Nashville this October 20th to 24th. And, we're really excited about developing interprofessional networks, and wanted to extend an invitation to anyone watching this webinar who may want to join us there. We have a special code. You can get the member rate if you use the AIHM MEM discount code. And if you don't have an account with AAFP yet, you make a free account and then you can join us. We're really excited at what kind of productive conversations can come, and building interprofessional networking. So, yep, thanks so much, and enjoy the presentation.
Thank you, Jess. And I actually have one last thing to say, jumping off from what Jess was talking about before I give it over to Brandon. And that is that coincidentally or otherwise, our chapter has been taking its own lead in trying to promote the webinars, seminars, and other events of other integrative medicine organizations of one kind or another. I just announced an incredible class for acupuncturists that the OAA, the Ohio Acupuncture Association, that's my professional association, is sponsoring. And I'm not going to go into the details here, but it is really like going to be an amazing opportunity. So I announced that one, and the OAA announces our webinars. And then the Cleveland Clinic is doing a really incredibly intensive 1 day wellness and preventive medicine seminar at the Cleveland Clinic at the end of this week on Friday, as a matter of fact. And I have asked Dr. Robert Saper, who heads the integrative medicine department there, if he would announce our webinar, and he asked if I would announce theirs. So, I mean, this is not just like one hand washing the other. This is really about getting out of our silos, not just as individual professions, which that's what something like the AIHM is designed to do, put people from all professions together. But even within our organizations, we tend to remain in silos. So that's why I want to promote the OAA and the Cleveland Clinic's integrative medicine and UH and so on and so forth. And this way we build like a great community in ways that we wouldn't be able to otherwise. That's my take on that. So with all of that, Brandon, the floor is yours. Thank you.
Thank you, Peter. Appreciate it. And thanks to the AIHM for hosting. So hello, everyone, and greetings from rural Wisconsin, wherever you are. So I'm going to jump right into the presentation here. Let me share my screen and we'll get started. Okay. Now, Peter, can you see my slide? No problem?
I can see him. Yeah, no problem.
Wonderful. Okay, then we're good to go. Again, thank you, everyone. So first, just a little bit about me. I've been in private practice for 20 years, and 10 years into that stint, I started having episodes of very severe abdominal pain, nausea, vomiting. These episodes were happening more often. They were getting worse. At one point, I went to an urgent care and I was sent home with a diagnosis of IBS and a prescription for Zofran. And then on a particularly bad night with an episode that I was having, and I was laid out on the bathroom floor, I told my wife I need to go to the emergency room. So there we went, and a wet read of a CT scan later, the physician came in and said, you know, your abdomen is filled with lymph tumors. And one of them, 4 inches wide, was causing a bowel obstruction. And so that launched my cancer journey. A bunch of blood work and testing and PET scan and such later, and then a bone marrow biopsy, which was positive, ultimately resulted in the final diagnosis of stage 4 non-Hodgkin's lymphoma. The particular subtype is called follicular lymphoma. It's actually a cancer that's typically seen in people in their 70s and 80s, and here I was in my mid-30s with this diagnosis. So in addition to going through the cancer journey, now both as a clinician and then now as a patient, I really had to wrap my head around what was happening to me. And I consulted with a lot of friends and colleagues of mine, and I framed out an integrative protocol for myself. Now that included, conventionally speaking, an immunotherapy drug, which is appropriate for my case, but it did not use chemotherapy or radiation and surgery, the last two, which were not even applicable in my case. And I'm happy to report that within 8 months, I was completely in remission with a clean PET scan, and I have remained so over these last 10 years. And I don't say that to sound cavalier. Cancer was an extremely humbling experience and one of my greatest teachers. So with that in mind, we're going to talk about psycho-oncology, and again, kind of my thoughts about what I have framed the anti-cancer mindset. But before I do that, I just want to wish everybody a happy Earth Day. This is a beautiful photo that was taken on this recent Artemis 2 mission that did the flyby around the moon. So just gorgeous. Want to share that with you, and happy Earth Day, which every day is Earth Day, right? Okay. So here is the big picture view. And what I'd like to tell people is that to get the best outcome, it is helpful, of course, to have an oncologist on your team, and they are the disease expert, but it's also equally as important to have a holistic practitioner that is acting as the health expert. And so where those two meet here in the purple is integrative oncology, which I would argue is where the best possible outcomes will occur in the context of one last piece, which in this Venn diagram, this centerpiece, which touches everything, is what I call the anti-cancer mindset, which really is how we think about cancer. And in two words, what is that? It's really all about patient empowerment. Now, the foundation of that does rest, of course, in compassionate medicine delivered by knowledgeable providers. But it also has a lot to do about a patient's internal narrative. It's about the story that they are telling themselves and how we can positively influence that story as providers. And so, even though we are genuinely interested in what disease the patient has, we need to be equally interested in the person that has the disease. So we're going to get right into the heart of that. And I'm going to answer this question for you. But before I do, I want to take a step back and speak much more broadly about how we think about disease in traditional Chinese medicine, particularly if that form of medicine is new to you. So that's my native chord. I went to graduate school to learn acupuncture, Chinese herbs, and so forth. And in my read of the classics of Chinese medicine, which are a few thousand years old, we really say there's only one cause of all disease. And as this picture illustrates, that causes an imbalance with nature and natural rhythms. Now, it's pretty self-evident for most of us. For instance, you can't go eating processed, super processed, food day in and day out without expecting to develop some kind of nutritional deficiency. And likewise, you can't go sleeping 3, 4 hours a night, night after night without expecting something to break in your body. So it's just as straightforward as how are we living within the natural rhythms of how we've evolved as a species. And from that one, we can drill down that one cause of all disease into two phases of the disease. So this may be a familiar symbol to you. This is called the Tai Chi symbol. It's comprised of both yin and yang, the yin being the black and the yang being the white. And here we can say, well, disease, even though it's an imbalance with nature, kind of occurs within two arenas, both external to the body and internal. So you could think of that as perhaps internal as being your genetics, and external maybe epigenetics, or what causes those genes to express themselves. Or alternatively, you can think about internal would be something like perception and stress about the events that are happening, and external could be something like an infection. So where these two meet for me is the art of medicine, how they interface and how we interface with it. And then from the two, we drill down further into the three. And in Chinese medicine, we have these three treasures, Jing, Qi, and Shen. And these are now levels in which we can work, right? And so I think of Jing as being like our genetic potential. So this includes the physical body, biochemistry. Qi is the biofield. So this is now biophysics. This is the electromagnetic system of the body, that both the central and the peripheral nervous system. It's also the piezoelectric aspect of fascia, which we leverage to great effect with a modality like acupuncture. And then finally, Shen is a way of suggesting consciousness. So our thoughts, beliefs, perceptions that come to bear. And then from the three, we're going to drill down one final time into thinking about now the 5 elements of traditional Chinese medicine. And here, this is where I say things get very practical, and this is where we tend to work as integrative or holistic providers, right? So going from left to right on this slide, for instance, with the earth element, maybe we're looking for nutritional deficiencies. Now, as it pertains to metal, maybe we're hoping to diagnose and treat acute and chronic infections. With water, we're looking at all levels, physical, mental, emotional, and even spiritual trauma. With the wood element, we're looking for the influence of toxins and toxicants. If you don't know the difference between those two words, toxins are biological, like from mold being a mycotoxin, and a toxicant is something that's artificial. For instance, something like bisphenol A or BPA, the plasticizer. And then finally, within the fire category, there is the aspects of relationships, community, life purpose, something that's actually pretty well acknowledged within the blue zone literature. So these are the 5 areas with which we work. So with that little primer in place, we can return to this question about what causes cancer. And if you ask anyone, just pull them over on the street and say, hey, what causes cancer? You'll likely get the answer that's most conventionally proffered, which is that it's a disease of genetic mutation. But we also know as integrative providers that there's a big influence with epigenetics. And so with the understanding that genes load the gun, but environment pulls the trigger, we can kind of have a sense that there's a lot more at play. And to start with, we have this idea of somatic mutation theory, right? Which just from a conventional perspective, again, over time with aging, we will all eventually develop cancer. There's a bit of a fly in the ointment of this particular theory. And that is, there has been a pretty significant global increase with cancer over the last few decades, and in particular, early onset diagnosis. I happened to look into this. The British Medical Journal of Oncology did a study on this, and between the years of 1990 and 2019, so within about a 3-decade span, there has been a 79% increase globally in early onset diagnosis, and that's defined by under the age of 50. So that would include me in that statistic, being diagnosed in 2015. All right. So, of course, somatic mutation theory is one, but there's also other theories that come to bear. And I have a question mark around this title on this slide, and that's because I think that they're not necessarily competing, that all these theories kind of have a place and they likely overlap. But let's just take, for example, that the somatic mutation is the way that things work. So we'll use that as an assumption to start with. Assuming it is correct, then the idea is that there are specific oncogenes that will express themselves with a particular cancer, like in this case, lung cancer. But of course, there is a pretty big difference between what is a root cause and a proximate cause. So in this case, the root cause being smoking is what is causing those oncogenes to express themselves as lung cancer. So root cause, proximate cause. However, proximate causes should not be ignored because they're a pretty big part of the equation. So with that, we have to understand that there is a difference between initiating and then promoting the cancer. Initiation, starting the process, and promoting, allowing it to fully express itself. Or again, thinking about things in terms of genetic or epigenetic level. And why that is important is because of this. If someone's been diagnosed with cancer, we may not have the ability to go back in time and to remove the cause of that. But in the course of our treatment, we may be able to influence the trajectory of that illness by looking at the contributing factors, which are often in our control, right? This is the terrain of the body, as it's called. And so using some examples of this, we have to parse out what is initiating and what is promoting. So here's an example of something that is unequivocal. If you are taking a walk through Fukushima and being exposed to ionizing radiation, at some point at a sufficient dose, you are going to be causing mutations sufficient to develop cancer, right? So that's a root cause that is so strong that it's unavoidable. However, on the promotion side, you can take an example of something like herbicides, which a lot of people are exposed to. We'll take the case of something like glyphosate, which is heavily tied to lymphoma. Now, a lot of people are exposed to glyphosate, but why do some people develop cancer and some do not? Well, in one sense, it could just be a dose effect, right? And not getting enough of it over a long enough period of time. But then there's also proximate causes, like in this case, stress, which may influence the body's ability to recover, detoxify from, heal from that exposure. And of course, it's not just stress, as we all know, it's everything. It's all these things compounded one on top of another. And so keeping that big picture in mind, I want to spend a couple minutes on this, my most favorite slide of my entire presentation. And it's really important, I think, for us to be grounded in the idea that there's multiple levels of causality, in this case, primary, secondary, and tertiary. So starting at the bottom and working our way up, I'm going to give you the example of a plant. So you can plant the seed of a particular vegetable in your garden, but that seed is very much dependent on the health of the soil it's being planted in, which is the terrain. But even then, that seed, even in perfect soil, is again completely dependent upon the environment. Are you going to get enough sun or rain? Okay. So in that way, environment is the single largest driver. And using this same algorithm then with the example of something like lung cancer again, yes, in the tertiary camp, you could have a genetic predisposition to lung cancer, for sure. But then in terrain, maybe you have a high stress lifestyle and a really poor diet that's disrupting the terrain of the body. But then in the primary environment, maybe you are exposed to secondhand smoke, maybe small particulate air pollution, maybe radon, maybe all the above, right? So these are all the things that are compounding themselves one after the other. They're all important, but I want to see the chain. I want you to see the chain of causality from primary to tertiary. Okay. Now, I'll finally answer this question. So when I hear this statement or when I'm asked, what causes cancer? Part of me thinks it's kind of the wrong question because when I hear that, I actually hear three different questions, maybe actually even a fourth, but three for sure. And those three are how we get cancer, why we get cancer, and even who gets cancer. And with maybe a small, spot for the fourth question, which is where we get cancer in our body. But I'll set that aside for now. So just looking at these three main questions, right? I'm going to return to this slide of the two phases of internal and external. So this explains the how, which is the external, and the why, which is internal. So for my answer to the question of how we get cancer, unequivocally, it's exposure to carcinogens. Now that's obvious. By textbook, carcinogens cause mutagenesis and then cancer. So exposure on the external level is one thing. But then in traditional Chinese medicine, we have this saying that all disease stems from an imbalance of the seven emotions. Now I simplify that for a Western audience by just saying stress and trauma. And that's the internal aspect or the why we get cancer. So again, where these two interface now is the art of oncology care. And I very humorously and affectionately called this the elephant in the chemo room, because these are things we're really not talking about in the same way as you're just having a genetic bad luck when it comes to the cancer diagnosis you just received. Now that's the how and the why. What about the who? Well, for that, there's been a lot of research in recent decades about trying to define what is a type C personality. And maybe you've heard of a type A personality in the sense that someone who is more prone to cardiovascular disease. But a type C personality and the bullet points that you see here are essentially the characteristics for people who are more prone to cancer. And this is not a stretch for people who are in the traditional medicine world like I am. We just think of this in terms of constitution, right? And so the internal landscape, which is now what we're going to spend the whole rest of this talk going over, really is comprised of these three things: constitution and our relationship to and exposure to stress and trauma. Okay, with that said, what is stress? Here is how I define it. And that is with the acknowledgement that not all stress is created equal. On a hermetic curve, obviously there are eustresses which are beneficial to the body. A great example of that is something like weightlifting. with resistance training, doing a certain amount, causing a strain on our muscles, and then getting adequate recovery time and nutrition will cause us to build lean muscle. But if we're doing that too often without the recovery interval, then we can become overexerted. The concept that we should try to get across to our patients is the idea of allostatic load, which is how excessive stresses combined, on top of one another can over time erode resilience. Now, as far as this question about what is trauma, here too, I have a very simple definition. And overwhelmment comes in different forms. So here it's helpful to parse out the difference between trauma lowercase t and trauma uppercase t. And the lowercase t usually is around things that you feel helpless around. Now, let's take for example that you're very concerned about conflict overseas, and you're hearing more and more about that on the news, and you feel truly helpless in the face of that. That over time is kind of like a small trauma, an inability to really do anything about it, and then hence cope with it. Now, trauma capital T is a bit different. And that is an event that happens that overwhelms you to the degree that dissociation occurs as a hallmark. Now, you could have big T trauma without dissociation, but it's often around along for the ride. And so it's one thing that we, think about and ask our patients about in terms of our interaction with them. So here is how I describe it or talk about it. And you're very welcome to steal this this analogy and use it with your friends and family and patients. And that is, you think about the calmness of your mind and emotions as being like a pond. Stress is like throwing little rocks in, little pebbles that cause ripples. Now, what you really got to do there is stop throwing pebbles in, and eventually the water settles out and you're good. Trauma is a bit different. Trauma is like throwing a big boulder in that displaces the water. So we need a fundamentally different approach for trauma than we do for just treating stress. Now, if you're in traditional Chinese medicine like I am, this is pretty obvious because we have different diagnoses for stress and trauma, and that's what they look like. And now to the central question, is trauma or stress a cause or contributor? I will give you my opinion. Now, that's keeping in mind that, as previously discussed, contributing factors can be potent promoters of carcinogenesis. And so my opinion is that stress is a very potent promoter of cancer, but I think that trauma is actually a cause of cancer in and of itself. Okay, so before I get into that, I just want to make the statement that even though I'm saying that, I don't actually explicitly make that claim in, for instance, any of the books that I've written on this subject or anywhere on my blog. I keep it open-ended and I let my readers decide based upon the evidence that I present to them. So having said that, we don't necessarily have the absolute damning conclusive evidence within the Western paradigm that trauma is a cause of cancer. We do have some very interesting animal studies. We have human studies about site-specific areas, like, certain kinds of cancer, and we're going to look at those in here in just a moment. So it's for you to kind of make the connection, as it were, given the evidence that is presented. And that goes all the way back from this interesting study that I found from 1982. Now here, we're looking at the concept of tumor rejection, but this is an extremely clever study in the sense that the stress that's being imposed on the rats is a shock. But the fact that they cannot escape the shock is what the trauma is. So the shock is the stress, the inescapability of it is the trauma. And then you're seeing, in this case, in this study, an inability to reject the tumor by the immune system that is accentuated in the inescapability of the shock itself. So interesting, maybe not super compelling. But then if we look over into human studies, this is a 2019 study that looked at over 49,000 women. They followed them up for 26 years. And then women in high PTSD symptoms have at a twofold higher risk of ovarian cancer versus women with no trauma exposure. So that's a pretty big study. little more compelling. Now, this is a retrospective study. However, here's a corroborating one from 2023, which is prospective. And here we see that women with 3 or more distress-related factors had about a twofold higher risk. So again, this is within the ovarian cancer world. So that's interesting. But I think the thing I want to really get across to you is this central thing, which for me, the reason why I put trauma in the camp of being a true carcinogen is that trauma and cancer for me have an identical definition, which is this: a wound that isn't healing. And I'm not the first to suggest this. When I originally heard it, is cancer is a wound that doesn't heal. Now, I didn't like the deterministic feel of that, so I changed it to isn't healing, with the acknowledgement that whenever there's a shock to the system, whenever there's a dissociation, whenever there's water being displaced from that pond that is our mind and emotions, it's almost as if it's causing a wound that is not healing, that is festering. And it's our job as providers to see to that wound and heal it in a very different way. So that's the trauma piece. What about stress? Now, here too, I think it's pretty unequivocal that stress is a potent promoter of cancer. And there are direct consequences of chronic stress, which you see here, right? And we're going to talk a little bit more about measuring stress and the fallout from it. But then here's the even bigger one, I think, in many regards, and it's indirect. Think of the 2 biggest things that people do to cope with stress: drinking alcohol and smoking cigarettes or other tobacco products and vaping and such. And those are direct carcinogens, right? And as if you ever, I do some work at helping patients to quit smoking. It is a very difficult thing to get them to maintain that cessation long term if they have been self-medicating with, in this case, like tobacco products all along. We also have to realize too that helplessness and hopelessness, again, if they're forming trauma from their chronic exposure, can be significant. And this is how this looks like. So, if you're feeling stuck, there's this progression from chronic stress to helplessness. And then if that goes on over a long enough period of time, that it could develop into a really big trauma. So all that association said, let's talk a little bit about the neurophysiology to give you a little bit more appreciation for me making those bold statements. So briefly, I'm not going to spend a lot of time on the science here, but the autonomic nervous system, of course, we all know is divided into 2 branches. And thanks to Walter Cannon, we know that acute activation, or I should say the sympathetic activation, can be either acute or chronic. This is what the acute looks like, and it's mediated by the SAM pathway. And the main thing you want to take away from this slide is the fact that it's catecholamine driven, right? And there is immune activation there. But when it comes to chronic, this is where we switch over into activation of the HPA axis, and this is now cortisol mediated. And here is where I think the rubber hits the road, because here's what we see: increased blood sugar and immune suppression. So chronic stress has a totally different flavor than the acute stress, and working through that. Now, stress processing happens largely through the hypothalamus. This is looking at biochemical or metabolic stresses. But all that is also funneled through our limbic system, and particularly our amygdala. And so this is where perceived stress really can have a profound impact on our stress handling capacity. And I'll give you an example of perceived stress that I think is a fun one, which is, if any of you have seen the movie Free Solo, Alex Honnold, who is the person in this movie who is free soloing, in this case, climbing up El Capitan without any ropes, which if he falls, obviously he'll die, is a pretty extreme movie. And I remember the first time I watched this movie with my wife, and so first of all, we know he survives because, he speaks after the movie, but still, it doesn't take away from just the other stress and terror of seeing him go through some of these difficult maneuvers in his climb. And I remember at some point reaching my hand over to my wife's, and our palms are just completely sweaty, right? We're totally locked into this experience, and the perceived threat in our nervous systems are just on fire because of it. So that's how potent perceived stress can be. All right. So, of course, now the rest and digest component of this is the parasympathetic activation. And to acknowledge that this is both our steady state of being and that it can be influenced. And Dr. Herbert Benson, in his 1970 book of this, named The Relaxation Response, he studied practitioners of transcendental meditation, and he was really able to define that there is a fourth phase of consciousness. Right? It's not just being awake, being asleep, and dreaming. There's this kind of alpha brainwave that we can influence in a meditative state. And then finally, there's this component of the nervous system, which is vagus nerve activation and the freeze response. So this is the deer in headlights effect. And for humans, how that appears is dissociation or our response to extreme stress and trauma. Now, it's interesting, the shaking recovery aspect. So let's take the example of this gazelle that you see in the picture. This is the observation of Dr. Peter Levine, who is the founder of somatic experiencing. He noticed that if an animal, a prey animal, goes into a freeze response and let's say locks up, it's ready for its demise, basically at the jaws of a lion. But let's say that hunt isn't consummated, and for whatever reason the lion takes off. After the animal comes out of its freeze response, the first thing it will do will be it'll tremble from nose to tail. The entire animal will tremble as if to discharge this nervous system activation of the freeze response. And if you watch children, they'll actually do this too. They'll fall off the swing and they'll be super scared about what happened and they'll get up and they'll be shaking a little bit. And this is a healthy response that comes from this vagus nerve activation. However, adults don't tend to do this. They'll get into a car accident. They may be out of sorts and dissociated, but there's not this completion of this pathway of causing this discharge. And so this was the observation of Dr. Peter Levine that led to a treatment modality specific to trauma for recovery, which we'll talk a bit about later. And then lastly, polyvagal theory, which is the work of Stephen Porges, it posits that we receive cues of threat and safety through the tone of the voice and facial expression. So this myelinated branch of the vagus nerve that goes above the diaphragm, right, goes to our ear, goes to our face. And so there's a significant difference between, the smile and the soft voice of a mother to, to soothe their child, as opposed to someone who has an angry look on their face and a sharpness to their voice. We know what that means. We can interpret that accordingly and regulate our nervous system one way or the other. All right, so let's talk a little bit about measuring the stress response. Probably the most straightforward is heart rate variability. So if you want to get equipment in your clinic to do so, it's extremely helpful and can show patients where they're at in terms of their resilience. By proxy, we can also test adrenal function. There's some old school ways of doing that. I'll describe these briefly. Palatal arises when you tell someone to say ah. And when you look at the palate, you'll see if there's an asymmetry between left and right can be indicative of an adrenal issue. Also, shining a light at the pupil. Is it able to hold that dilation, or does it look like it's fluttering and wants to give up? That's also a sign of an adrenal insufficiency. Ragland's test is basically a change in blood pressure. If you take the blood pressure sitting down, that's one metric. But if you have them laying down, take your blood pressure and then take it again when they're standing. If there's a drop in blood pressure, in which case the baroreceptors of the neck are not able to maintain the increase of blood pressure needed with rising, that's also a sign of adrenal insufficiency. And finally, in my world, if you're diagnosing through pulse tongue and such, we look at kidney deficiency as being correlative with an adrenal insufficiency. Of course, if you want to get fancy, you can always measure cortisol, right? It's a great way to do it. Protein-bound serum cortisol doesn't give us a whole lot, so we tend to look at the free cortisol that's measurable through saliva and urine. And that's often done through a 4-point morning through evening, and to get a sense of the architecture of the curve itself. Is it too high? Is it too low? Is it just right? Another thing we can do is look at cortisol awakening response, which is how precipitously Cortisol rises within the first hour of the day, and that's an excellent, in some ways, even a better indicator of resilience than just a 4-point daily cortisol diurnal rhythm. And there's also looking at metabolites, which is pretty interesting too, because even if someone's cortisol, 4-point cortisol rhythm is normal, if their metabolized cortisol is really high, that would suggest that they're just blowing through it really fast. Maybe they're compensating, it looks great on paper. But if their metabolized cortisol is really high, then you know that there's still a high cortisol burden in the body. Also, this is actually a test that I use. It's the Dutch test by Precision Analytical. And I also really appreciate where they have this, there's a systemic preference between cortisone and cortisol. Preference for cortisone itself is more indicative of high stress and infection, and a high cortisol preference is more indicative of insulin resistance, inflammation, hypothyroidism. All right, measuring trauma. It's a little trickier. We just don't have a blood test or a urine test for it. So obviously there's the clinical diagnosis, right? Someone who has a PTSD diagnosis, past trauma. But the thing we probably rely on most is what's called an ACE score. Now, the CDC, who did a survey of 17,000 adults in an effort to understand the relationship between childhood trauma specifically and instances of disease later in life, found that it is actually the category of these things, not the number of times it happens. So if psychological abuse has happened once for a child, you check that box. And so what they found is with an increased number of these, in terms of categories that a person or a child has experienced, we do see an increase of heart disease, substance abuse, and cancer. Right? Then there's this lingering question of who gets what disease, right? And that's where I, can revert back to this idea of type C personality and constitution. And then, of course, obviously, there's that how and why of cancer. What else are we exposed to, like carcinogens that are collectively, framing this potential. Okay. In addition to that, it's really helpful to look at what a patient is telegraphing to us and using your clinical skills accordingly. So here's one example. Okay. So here's some examples of fight language, what someone might say. How often do you hear these things? And then here, some examples of fight language. I'm so done with fill in the blank, right? Also pretty common. And then here's freeze language, right? Here's a common refrain. I swear I hear this probably every day in clinic. A patient comes in and they say, I don't know. They're just like, yeah, I don't know. I don't know. And I just want to and I often do, I just say, yes, you do know. Tell me what's going on. Speak your mind, speak your truth, right? Whatever. But I don't know is another example of this freeze language. I don't know what to do. All right. And then also, much of language is nonverbal, right? So body language, look at this person. What are they trying to articulate? Okay. So let's think about some therapies and strategies. And I'll spend a little bit more time on this before we kind of wrap things up and hopefully have some time for questions. So as it pertains to stress, there are different types that we can leverage. So there's active, passive, and there's stress proofing. So let's look at each of those a little bit. We'll start with active. And here's where I feel like people probably need the most education on. Because someone might say, well, my de-stress is, reading a novel or quilting or something, right? What have you. And those are great. Those are great hobbies. But that's very different than having an active strategy, which is building resilience, right? Lowering stress hormones, as it were, in a very active and, good fashion. And so, meditation's probably my go-to personally, but also be aware that not everyone's ready to sit for any length of time. And so that some forms of meditation like Qigong or Tai Chi are also very appropriate, moving meditations, right? But meditation can be pretty key for a lot of people and help in terms of building stress resilience. Another big one, which I'm really promote heavily, is breath work. And here you've got lots of options. The 4-7-8 ratio is the famous relaxation breath that Dr. Andrew Weil promoted, a few decades ago. And it's still tried and true. And the idea here is you want to breathe in for a count of 4, hold for the count of 7, and breathe out for the count of 8. And whenever there's this lengthening of the exhalation in particular, a long exhale does stimulate the vagus nerve. Another one, which is quite helpful, is box breathing. And this is where you're going to have an equal breathing in, holding, breathing out, and holding so that it looks like a box. So you're going to be limited in this case by how long you can hold the breath during an exhale. So let's say it's 4 or 5 seconds, but by doing so, you have this nice rhythm that you're creating between these 4 intervals. Now, curiously, when I kind of first heard about this, I saw a video of a Navy SEAL who was teaching box breathing, and he was teaching it from the lens of, he was calling it tactical breathing, right? So this is an idea that you can teach special forces people that if they're under fire, they can revert to a box breathing, and then to help them regulate themselves and get out of that, acute stressful situation. So it's helpful acutely, and it's also helpful to do on a regular basis to also build resilience. I do both of these every morning. It's just part of the kind of tail end of my meditation, daily meditation. Journaling is also wonderful. It can be done a couple different ways. You can do it as a gratitude journal. You could also do it as a catharsis journal. What do you need to get out of your system, and to write it all down. I'll tell you who this is perfect for. If you are the type of person, or the type of person who they clench their jaw a lot at night, and so they wake up with neck tension or headaches, they can really benefit from journaling. Have them write stuff out before bed, because essentially what's happening is the things that are unresolved during the day, they're cogitating on it all night long. It's entering into their dream state, and they're clenching their jaw around that. So to be able to journal and have that catharsis before bed can be extremely helpful. All right, and then there are the passive strategies. So the active ones can be a focus, but then also realize that passive ones play a pretty significant role too. So here's some obvious. I'll give you a couple obvious ones. Exercise is definitely up there. We get endorphin release from that. Balances neurotransmitters. And, it doesn't have to be in the gym. I encourage people to go outside, right? Maybe do some forest bathing, hug a tree like you see here, breathe in all those volatile oils from the evergreens around you. You can get into a forest. So you can have multiple benefits stacked on top of one another when you do something like exercise outside. And then, of course, there's restorative sleep, not to be underestimated, right? This is our body's key way of kind of coping, is to just knock out a little bit and let things resettle themselves. You can definitely hibernate if you choose, like these bears here in this picture. All right, I'm just going to say, because I know not everyone here on this call is a practitioner of traditional Chinese medicine, but I want to put one clinical pearl out there for those of you who are, which if you are an acupuncturist, this is a protocol that I kind of developed over time. I first wrote an article about it about 10 years ago. It appeared in Acupuncture Today. And I call it B5NP, which stands for Brain 5-Needle Protocol. So it's, not 5 needles in each ear like you would know from the NADA protocol, but it's 5 needles total, 2 in each ear and 1 here in the center, which is the yin tongue point. And so this is what it looks like. But even if you're not an acupuncturist, what I want you to pay attention to is this second point in the right ear, in this area in the microsystem of the ear called the liver and kidney area. It's kind of like right in between the two. More on that in a moment. But for those of you who are acupuncturists, this is kind of what it looks like. Right here in the left ear, we have Shenmen in the 0 point. If you're gunning for this one, the 0 point, just really try to feel for that notch in that part of the ear. That's where it is. And then in the right ear, the top pin here is the sympathetic point, but the lower one is this region, which is in this kind of liver kidney area, kind of right in that zone. Now, this is why this spot is important, and you don't need to be an acupuncturist to take advantage of it. And that's because this is the only spot on the body where the vagus nerve is superficial, comes to the surface. And this is precisely why in research, this is the area that is often used for transcutaneous vagal nerve stimulation. So it can be stimulated by any number of means, like in this case, this device that's being used. But an acupuncture needle, acupressure, ear seeds, any of those things are suitable for work in this regard. All right, and then a couple words about stress proofing. This is essentially exposure to controlled stressors in order to build resilience. And this falls into two categories. One of them is cold exposure, which you could do a number of different ways. You don't need to have an ice bath like this gentleman here. You could do it in a shower with some level of cold exposure by turning it all the way to cold. My thoughts on this is if you choose to do this, very clearly, when you turn the water to cold, your mind is nowhere else. You are absolutely locked in. You're not thinking about your taxes. You are thinking about the cold and getting away from it. So the benefits, though, really are derived from when you start to slow your breathing, because initially what happens when you turn it to cold is you start to hyperventilate. Oh, it's cold. But then you start to slow your breath, and that's where all the benefits lie. It's being able to put yourself in a stressful situation and say, I'm going to nip it in the bud. And for that, it's glorious. I mean, it really has some benefits. The cold also has this endorphin releasing function as well. So that's kind of cool. So there's some different ways you can do it here in these bullet points. And then there's the opposite extreme, which is hot, right? If you get into a sauna, it can get uncomfortable at some point. But do you sweat that out? Do you just, go with it, hang in there for a little while, calm yourself, and then you have the benefit that way too. And of course, you have the detoxification benefits from sweating. So there's a 2-for-1. Okay, let's talk a little bit about trauma-informed therapies. And here you have options. The two biggies are top-down and bottom-down approaches. And the top-down ones are the cognitive reframing strategies. That's kind of using up here, right, your thinker. And the bottom-up ones are more somatic. So they're embodiment therapies, and they both play a role. Looking first at the top-down ones. This is when you're actively working with your psyche on some form of cognitive reframing. So thinking about the things that have happened to you have occurred, and how do I think differently about them? Instead of post-traumatic stress, we think about post-traumatic growth. How do we reframe in order to derive, our strength and empowerment from the things that have occurred to us? And so there's lots of different ways to go about this. It could be traditional psychotherapy with something like cognitive behavioral therapy, but it could be something a bit more off the beaten path like EMDR or meridian tapping. They all tend to work, and so I just encourage people to find what works for them. And then there's the bottom-up approaches, which I have, in some ways, more interest in and discussing with patients, because these are the ones that they're less likely to have encountered. And so if they're already a heady person, the top-down ones are great, but maybe where the work really lies is in an embodiment practice. This is 100% true for a child who has encountered trauma in a pre-verbal state. So before they start talking, they often don't even have the words and the ability to express what trauma has occurred to them. For them, almost all of the healing is going to have to be on a bottom-up approach. All right. So there could be trauma-informed yoga. There's things like somatic experiencing. So all these are excellent ways to kind of get us back into our body, what we're feeling, how we're expressing ourselves, and so forth. And then finally, there's this little third section of spiritual and religious oriented practices. Now, The one that I favor in this camp is shamanic counseling. I've done a lot of work on this myself and have studied it, and I find it's really interesting that in a shamanic lens, there's this concept of soul retrieval, where a part of your soul is kind of lost at the site of a trauma, and that the job of a shaman is to reacquaint you with that lost soul part. So that's really interesting. The one that's getting a whole bunch of interest right now is this last bullet point of the psychedelic assisted work. And here we've got psilocybin that's being used for end of life depression in cancer patients, and MDMA for PTSD. So you're going to, if you haven't heard yet, there's going to be a lot more that you will hear on this particular therapy as it relates to both stress and trauma. Okay, how about a quick clinical pearl? So let's say you've got someone in front of you who is, they are, as my daughter would say, my teenager, crashing out. And they're just losing it, right? Maybe you see them entering a state of dissociation. This is a technique I learned from Donna Eden, who is the author of the book Energy Medicine. So for the acupuncturist on the call, gallbladder 15 is the area. But for the rest of us, if you can see me on the screen, when someone hears bad news, they tend to do this. Oh my God, right? So like it's called the oh my God points. And the act of putting your hands up to your forehead is just this intuitive thing that we tend to do when we're in crisis. And so if you have someone in crisis in front of you, encourage them to do this if they're not already. So what's happening? On some level, when that stress response is being initiated, blood, which should normally be right up here in the prefrontal cortex of the forehead, where this is our thinking, rational thinking part of the brain, is now leaving this area and it's going toward the limbic brain, right? That's the reptilian part of our brain, to help deal with that stress. So we can counteract that to some degree by putting, even if you just take your whole flat palm of your hand and putting it on your forehead, what you're essentially doing is the heat and the electromagnetic signature of your hand is now creating this countermeasure where the blood's going to start flowing back towards your hand. And so this can very acutely pull someone out of that dissociation state if they're, so very helpful. All right. Now to close out, I want to have a little bit of a discussion here about, I think, the crux of my work, which is this anti-cancer mindset piece. And for that, I don't think there's anything magical about mindset, but there's definitely a difference in someone who, coming from a growth mindset, is engaged in the process. They're going to have a fundamentally different experience than someone who's locked into a victim consciousness. So we need to encourage and cultivate a growth mindset. But one of the things we need to do is address head on the fears that are associated with cancer. And there are 4 that I've identified. So the one that is the most obvious is if you hear the word cancer and you've been diagnosed with it, is the fear of one's mortality, right? And that's what I would think any cancer patient hears immediately. I know I did. I think, is this going to kill me? That's the first thing that crosses your mind. But even if you work through that fear initially, and you're going to undergo conventional oncology treatment, you may have a very significant fear of the treatment itself and all of the fallout in terms of the side effects, which is no small matter. And then, even if you are successful in achieving remission, then you're also potentially living with the fear of relapse. And then finally, there's also the fear of diagnosis itself. And so, for example, someone might say to you, yeah, my mom died of breast cancer when she turned, around the age of 55, and I'm about to turn 55, right? There's this buildup, there's this fear of cancer itself, which again is no small thing. It's something that's rampant within in our culture. So the antidote to this is the anti-cancer mindset. And these are the hallmarks of it. To be engaged in the process, to, by extension, then have an adherence to whatever protocol that you choose. And I have to say up front that when I consult with cancer patients, I am very clear that I don't have a dog in this race. By that, I mean, if they want to do full-on conventional oncology care and they just want me to administer acupuncture for the side effects, I will back their play 100%. If they are much more of a holistic bent and they want to take a few elements of conventional oncology care and they want me to talk to them about diet and lifestyle and maybe some herbal therapy or what have you, I'm all in. I'm on board for that as well. What I don't want is someone who's waffling, right? I want someone to be 100% on board and engaged with all their heart and mind in the process. That's the anti-cancer mindset. Someone who's, again, engaged, they're ready to go, they want to put all in for where they're at. And then finally, surrendering to the process, because obviously there's things that we can't control for. So all three of these need to come into play. And essentially, we can do that by understanding this concept of salutogenesis, which is the study of health instead of disease. Now, Viktor Frankl, if you are familiar with his work, he wrote an amazing book, Man's Search for Meaning. He was a Holocaust survivor and the founder of logotherapy. He states that for any significant duress that we are under, we need to derive three things from it. The experiences that happen to us, they need to be understandable on one lens, but they also need to be manageable. We have to find a way to manage that. But then ultimately, the top of the pyramid here is they have to be meaningful. We have to derive meaning from the experiences that we are encountering. And so my solution to this is inquiry, right? In true philosophical nature. How do we pull this out of people and our patients through inquiry? And so here's some examples of questions that I often pose to cancer patients. And all of these questions are in the back of my second book, Cancer, Stress, and Mindsets. So don't feel like you have to write them down. But these are the questions that at some point along the line, I'm going to ask my cancer patients these questions. And the first one, the second one of this first grouping of them is the difference between, someone making that claim and then what other people would say about them. So that's kind of interesting. Here's the next grouping. Now, the second question of this group is interesting, and I make this distinction of between dying and death for a very important reason, because dying is the fear associated there is the fear of suffering, right? But death is different. The fear of death could be more about unresolved issues. What am I leaving behind, right? And so it's important to delineate between those two and ask them accordingly. And then finally, these are the three that I feel like I never want to miss. This is the most important ones for me. And with this first question you see on the slide, I'm really looking for someone who has a trauma history. Like, where have they checked out? Where has been the dissociation? And then with the next question, I'm already starting to shift someone towards a growth mindset, right? I want to say to them, how can we build a roadmap here? How can we use cancer as a teacher? How can we use this to make you a more empowered person? And then finally, this third question, which comes on the heels of that, is asking this so we have a destination. Where do we want to go? What is the vision for yourself that we are working towards, right? And then finally, with that all said, here are my questions for you, which is, and this is particularly if you are a new practitioner, what kind of practitioner do you want to be? Curing symptoms is wonderful. We're all in this to alleviate suffering in the world, but we also know that there's a difference between healing and curing. And, what are we doing and how are we engaging with patients to help them become more empowered? And for me, that's everything. That's where the rubber hits the road, is returning to this slide, delivering compassionate and well-informed healthcare, yes. Working with the patient, shaping their narrative, but to what ends? And that end really is the empowerment of the individual. There's this saying, right? When death finds you, let it find you alive. And I think it cuts right to the heart of what I'm trying to communicate to you. And that is, yes, it's our job to help heal patients' cancer so that they can live. But we also need to help them to live so that they can heal. It works both ways. And so, leaving you with that thought, I also want to extend a gift to you. So these are the couple books that I've written on this subject. And if you've hung on to this call as long as you have and listened to me blabber, I want to extend a gift that if you are on this call currently and you are a clinician, and if you work with cancer patients, even if you don't specialize in it, but if you see cancer patients to in any regard, I would be happy to send you one of these two books. So feel free to send me an email, give me your physical address. I am so passionate about my work and getting this message out there that what I would offer to you is pick whichever one of these you like, whether you're more interested in the kind of the more Western stress aspect and the headiness of cortisol and all that, or if you want to dive more into the trauma, emotional, spiritual piece. I will offer you one of these two. If you want to throw me a bone and buy them on Amazon, great. But I'm also want to get the message out there, and so I will be happy to send you one to have in your lending library for your patients. And with that, here is my contact information. The top link goes directly to my blog where I'm writing all sorts of interesting things these days. I post once a month. You can go through my whole back catalog of crazy things that I've written. And then the bottom link is just to my author website, and you can contact me right through there. So, all right, with that, I think I've spoken long enough, so I'm happy to take some questions and we can discuss things. Let me stop my screen share so I can actually see that. And
And that was fantastic. Thank you. It was great talk. I think you covered so much material in such a short time. I wish you would go on for another hour, actually. Um, it doesn't look like we have a ton of questions in the Q&A, but I usually like to just start the ball rolling anyway, orally. So while I'm doing that, then anybody else, while you're thinking of your own questions, please put them in the Q&A.
yeah, I can certainly start there.
But so one thing I wrote down a number of questions, but I'm not going to hog the screen. I just want to ask first, when we talk about sympathetic activation, and at first it was always called the fight or flight response, right?
Yeah.
And then it was fight, flight, or freeze, as you have emphasized. But there's a fourth one that I don't think you mentioned, but that I've heard quite a bit about too, which is fawn, right? So it's fight, flight. Fight, flee, freeze, or fawn. So I was just wondering if you thought about this. The fawn aspect sounds like it's more maybe the most conducive to the cancer response to developing cancer, because that people-pleasing behavior or mollifying behavior that seems to fit in with your C personality. What do you think about that?
Yeah, that's leave it to you, Peter, for giving me something I haven't thought about.
Oh, good.
No, that's a good one. And I'm aware that the fawn is the fourth F, and it does absolutely, as you say, fit perfectly within that type C personality trait. So my thinking of that is, it's not any one thing, of course, right? It's multiple things coming together at once, which in the earlier slides, I guess I tried to indicate that, if we're really going to be holistic practitioners, especially with something like cancer, which is so multifactorial, we have to be so broad in our thinking. And there again, too, that's why I'm so invested in the philosophy of medicine and again, what I call the anti-cancer mindset. So clearly, as you just stated, the fawning aspect could be one way that we are coping with chronic stress or traumatic exposure. Um, and and I think it's important that you bring that up too, because there's definitely this little through line in the literature with cancer patients that the ones that are the most submissive in a way, that just do whatever their doctor says, actually don't get the best outcomes. It's the ornery patients that do. It's the one that have a little bit more, fight in them. They're moving for something that is more submissive, like the freeze response and the fawn response, to the fight response, which is something which is a little bit more engaging. Like in Chinese medicine, we say this is like the liver qi really getting activated. And, anger is a better state than fear in a sense, right? Now anger can cover over fear, right? It could be what's masking it. But if someone's engaged, if they're really like, kind of fighting back a little bit, that can be helpful. Now, having said that, I never chose the metaphor of fighting cancer because I felt like that was the wrong one. In my own personal cancer journey, for me, it was far more about using cancer as a teacher. So even though that I had some spunk around my process, and when I, for instance, I got a second opinion from an oncologist who was a lymphoma specialist. When she said to my wife and I'll never forget this, she said, because your disease burden is so high, I don't believe you'll ever be able to get in remission without, high dose induction chemotherapy. And, in the back of my mind, I'm like, you just wait. I'll show you. Right? So there is definitely a sense that if you've got some chutzpah around your process, that's also something that can be helpful. But yeah, so looked up about that. But thank you for that question. It's a good one.
I'm just going to throw one more and then I'll let everybody else pitch in. And if there's time at the end, I'll maybe ask a couple more. But the second one I want to ask you, I know I asked you not to spend too much time on your personal story because, you know, uh, it's inspirational, but, we wanted to get some other material across to our listeners as well, which you did. But I am going to sort of like retrench that a little bit. And I'm just going to ask you if you could say something more about not how did you go from a stage 4 to remission, but how the heck did you do it in 8 months? Like how did you get everything marshaled so fast and
Yeah.
corralled, whatever term you want to use, and get activated to that extent that you were able to affect that drastic a change in such a short time.
Yeah, I mean, I'm happy to speak to that, and I can give you. I'm fine about sharing specifics. I mean, with the caveat that it's an N of one, right? I can only share what worked for me, and that it
Yeah.
obviously will not scale to other people, and so you have to be wise about this. So the one conventional therapy that I leveraged was it's actually an old drug. It's called rituximab. So it's an immunotherapy drug that's specific for CD20 positive or markered B cells. So I had a B cell lymphoma. So the course of treatment looked like this. I had gotten an immunotherapy infusion once a week for 4 weeks. And then so after that month, I got a follow-up scan, a CT scan, and I had about a 30% reduction in tumor burden. So that was pretty good. But it's far from being in remission. So during that month is when I was really hitting it hard. I was doing all the research and figuring out what I want to do. And so after that 1 month of 4 consecutive treatments, then my oncologist said, well, then let's just do one treatment every couple of months. We'll do like 3 more. It'll take us towards the end of the year, and then we'll scan again. And that's when I really hit it hard. That's when I introduced a whole bunch of different therapies. So my diet was already fairly clean, but I mean, I went from 80/20 to 99/1, so I was very specific. And I have a lot of thoughts about diet. We can, if you want to go that direction. But I got a super clean diet is, I think, the point. I did leverage a lot of all sorts of medicinals. I think categorically the ones that I have the most faith in terms of the evidence, the weight of the evidence would be medicinal mushrooms. I think hemp as a plant for modulating the immune system is also high up on that list. Mistletoe therapy, which comes from anthroposophic medicine, or you might know it as Iscador injections, as its own kind of immunotherapy, is something that I utilized. And things like detoxification through sauna was something that I took a lot more seriously. But overall, and this is why I chose to write my books, is I really think that the single biggest driver was getting my head and heart in the game.
Mm.
I can't stress that enough, that for me, and again, this goes back to like the blue zones and having life purpose and having community. I really had to change my thinking. And I think the single greatest anti-cancer strategy we have is transcending fear and finding purpose again. And that can happen with any disease at any age. So again, I mean, I feel so strongly about it that the thing I really had to do the most was find my purpose and find my why. I'll give you one small example. At the time, my daughter was 2 years old when I was diagnosed. I could not fathom the thought of her growing up without a father. I mean, that was just absolutely unacceptable to me. And every morning in my meditation practice, I did a visualization of seeing myself as a grandparent. And I know that if I did that, I would well outlive my prognosis. Now, again, is there something magical about that thinking? Maybe, maybe not, but I can definitely tell you it galvanized me. It gave me laser focus, and every decision I made every single day was wrapped around that morning visualization. So that's where I really feel like the power of getting your head and the heart in the game is not a small feature. And that's something that we really could leverage to for any condition to,
Mhm. Hence the anti-cancer mindset.
correct. Right. Yes, you got it.
Okay, thank you so much for that, and I will let you pick up on the questions that you see.
Yeah, there's a few here. So the first one, I'll just read it. I don't know if the people who see the recording will have access to it. So, how accurate do you think the Oura Ring data is around HRV and resilience? I don't actually know the answer to that. I know it does provide significant HRV data. Um, I would say the one that I have the most faith in would be the Institute of Heart Math and the devices that they use. Those are the ones I have personal experience with. I think that are excellent. The Aura Ring is don't know, but it's at least one data point that you could consider. I know a lot of people use it for sleep tracking, which one of these days I'm going to actually write a blog post about why I think people should not use sleep trackers. The short of it is that they look at the data and that just is like their fate. It's like, oh, I had a bad night's sleep because my Aura Ring told me so. It's nonsense. You know when you wake up whether or not you feel good, if you got a good night's rest. So there's my part about that. Okay, next question. So is it sort of a blend of NAD, BFA? I don't know what that's in reference to. If you want to,
It
oh,
was
not
the
I get it.
ear.
Oh, not a
Yeah.
protocol. Yeah, I see it now. No, it's kind of my own thing. It's not necessarily associated with NADA, even though I kind of borrowed a fraction of the name for that one. So yeah, just my own thing, my own experimenting. Okay, hello. Thank you so much for a wonderful presentation. You're welcome. How do you work with patients who don't see or agree with any connection between cancer and emotional stress and trauma? Frankly, I don't try to convince them. Maybe I'll say, hey, I may sow some seeds. That's probably my best answer to you. If they're not ready for it, they're just not ready for it. I can't force them to look in that direction. Um, and maybe I'll drop some little hints here or there, or maybe they see my book, or maybe I'll say, hey, just give this a quick read, see if this is anything you're interested in, and go from there. But it's hard. Um, I'll just, speak from again, as a practitioner of traditional Chinese medicine, it's so, I mean, it's so self-evident. I mean, we don't separate the mind and the emotions and the spirit, right? It's also part and parcel. Um, so maybe it's just because people who are attracted to me and my practice are already kind of ready for that. It's hard to say, but yeah, don't force it, but if you, again, one of the reasons why I'm offering a copy of my book is for you to read it too. If I explain it in such a way that you feel like it's helpful, then feel free to, again, put it in your lending library. And maybe that might just be the impetus that person needs. Also wondering if we could get a copy of this presentation slide later. You'll have access to the recording, so it'll all be there. So there you go. All right.
And I'll add, there is a pretty great question, two questions in the chat from Donna. That brings up a couple of questions. How do you help patients avoid effects of, quote, medical hexing, like what you experienced with your second consult? And second, how do you help patients with decreasing medical trauma of upcoming scans and follow-up appointments?
Huge. So I wrote about the first part of that in my second book, Cancer, Stress, and Mindset, the medical hexing part. I have a whole section on that. And the fear around like testing is actually in my third book on cancer, trauma, and emotions. So I do give some time to those two subjects. And there's even a third one too, which is and I experienced this, which is, like in my case, there's survival guilt. Like, I know people younger than me that did not do well. They did not survive their cancer. And then you can internalize the guilt around that for someone who has, achieved remission. So there's all elements to this. The medical hexing part is we need to step up. We just need more. We need our voice. We need to be present, have more resources for patients. And And that's huge because, again, the point for me is patient empowerment. That is what I'm after. This is going to sound crazy, but I'll still say it. Cancer to me is not the point. It isn't. It really isn't. It's to me, it's like it's just yet another lens with which we can access empowerment as an individual. So when I have someone who's in front of me, to me, it's almost irrelevant what the diagnosis is. Yes, it's relevant. I'm doing the work, right? I'm educated. I'm giving compassionate healthcare. But what I'm after, like what I'm truly after, is someone who's engaged in the process, who's really stepping up, because that's the person that, again, that's where I'm accentuating life, not just preventing death. So for me, is to the question, the medical hexing thing is we just need different voices that are offering a different narrative. That's what it comes down to. As far as the fear around testing and such, here's my here's my funny way of looking at this. For those of you who have seen the film, the original, oh, what's it called? With Iron Man and Bruce Banner as the Hulk. You know the one, the Marvel movie. I'm forgetting the name of it at the moment. So there's this funny interaction between those two characters, the Hulk character and the um, Iron Man character, which throughout the the Iron Man character keeps kind of goading the Hulk. He wants to kind of turn Bruce Banner into the Hulk. And at the end, there's this big reveal where he says, "You know what my secret is? I'm always angry." Right? It's like he's been holding it back, but he can just let it loose. Right? This is the Avengers movie. Just finally thought of it. And so that's kind of my tongue-in-cheek way of saying it to patients, like, you know what, when it comes to cancer, the fear is always there. You just never technically get rid of it. You just learn to rise above it. You just learn to not control it even, but just live with it in such a way, maybe that the fear doesn't stay the same, but your box gets bigger that it's contained in, right? You just kind of grow and you become resilient enough that the fear just doesn't disappear. You just learn to grow stronger in the face of it. And that's what it's like. It doesn't magically disappear. You don't just get to do that, but you can learn to live with it, and I have as well. Sometimes it takes years, but it's possible. So, and Jess, was there another question in the chat you wanted me to field?
Yeah, well, they actually put it in the Q&A box now too, but why don't you just speak briefly to diet, around
Okay.
diet and nutrition? Yeah.
Yeah, I see that there. All right, so I'll tackle that one next. So, my opinion on this is very much not the mainstream, even in the holistic world. So you will definitely hear and read a lot about attempts to starve cancer by this diet or that diet. I don't know if that's possible. And I don't even think that's the point. I think to me, okay, within the greater umbrella of teaching people to eat, a diet that's clean, that's devoid of ultra-processed food with a lot of organic and local and so on and so forth. We know all that story. So within that umbrella, I think that the main thing that I try to get across to people is to just find your power foods. Find the things that work for you that make you feel good. Stop thinking of it in terms of trying to starve out cancer and start thinking of it the things that make you feel stronger. And yes, I mean, are there instances where someone might want to be on the lower carb or keto side of things? Clearly, there are definitely cases for that. And are there even cases where someone might be more on the vegetarian plant-based side of the equation? Absolutely. I think the person who really had this figured out the most, which was someone I met many years ago when he was speaking in my area, was Dr. Nicholas Gonzalez. And he passed away a few years ago. Um, but his approach was what it calls a metabolic type of diet, which means you're just kind of eating for your metabolic type, which comes down to the same principle. You're basically eating to nourish you. You're giving yourself the micronutrients and the compounds you need to heal yourself. And to me, that's way more important than trying to be fixated on, what's the diet that's going to cure my cancer. It's way more about nourishing yourself. So that's my opinion. There's a thank you very much. You're very welcome. And your questions that you ask are amazing. I'll ask, what brings you joy? What are your hopes? Where does your strength come from? Those are excellent questions too. Positive psychology focused. I love that. Thank you, Donald. Recently added, what matters most to you? People are very eloquent. How are the responses you get to those very deep questions? Yeah, great. So those are awesome. Those are good things to ask at some point too. So, right. Wonderful. Thank you for that. Thank you all for your very good questions. So it's much appreciated.
I'd just like to add one more thing about medical hexing, and I wasn't thinking in that term, but when you were talking about the fear of diagnosis, right? Uh, what I want to say is I think that a lot of that fear is based on the Western paradigm of, oh, your father died of a heart attack at 55. Family history. You better be careful. You have a higher likelihood of dying at 55 because your father did, or cancer, or whatever it might be. And that's like the idea that biology is destiny, which is exactly the opposite of what you're saying and what we're talking about here. So
Yeah.
I hate those kinds of pronouncements personally. I will just say publicly, there's one thing that I hate the most about Western medicine approach to disease diagnosis is like this idea that you are, destined to follow in the footsteps of your family and your family history. And that's just completely untrue. Even if there is a genetic predisposition for one thing or another, this is what functional medicine and all that stuff is about, right? 90% of our health is what we do with it, not just the genetics that are there, but what
Right.
makes the epigenetics. So, anyway,
And again, for me, the pivot point is, getting your head and your heart involved, right? Because that's what's going to make that decision and say, no,
yeah.
that's not my fate. I'm looking elsewhere. I'll tell you one quick story about that too. My oncologist, who is a great gentleman, and to his credit, he's the one who let me try. He wanted to do high dose induction chemotherapy because my disease burden was so high, and there was a threat, of course, the bowel obstruction killing me. But he knew kind of my background. And he said, okay, we'll just try, if you want to try a little immunotherapy and do your thing. He never asked questions, right? But again, to his credit, the one thing he never did was give me a prognosis. I never asked for one, and he never gave me one. And some level, he knew I didn't want it, but at the same time, he was also leveraging this principle of mindset and not putting that in my head. And for the same reason, again, I never went to a cancer support group. Again, this will sound crazy. I didn't want to feel like a cancer patient, right? So I found my support elsewhere, in different venues. So all these things matter, right? So
Oh, yes. Here,
thank you.
here.
Thank you, Peter.
um, you got 4 months to live. Sure, if you fix your mind on the fact on that statement and that thought, you probably will have 4 months to live. You will fulfill that. But if you think I have an unlimited amount of time to live, you're going to expand. So anyway, I don't want to belabor the point, but I just had to speak up about that. So I think that medical hexing is like a really major problem with people facing severe diagnoses.
Yeah. And
Um,
especially for the for people who don't have a religious or spiritual disposition, they look to the high church of Western medicine and the clergy in their white lab coats as in their proclamations as being the voice of God. I mean, we're that's what we really need to break, that kind of medical hexing that's almost on like a religious level, right?
Yeah, and I think that definitely has changed over the last few decades. It's changing, right? No longer do so many people think that because you're a doctor, you're a god, and you've got
Yeah.
the insight, the inline to everything.
Yeah.
Um, Dana, thank you so much for raising that point. Really good, important. Um, does anybody else have anything else for a last question or comment?
Someone just wrote in the Q&A, medical hexing nocebo belief so powerful, as if we get crystal balls passed out in school. Very true. Yeah.
That's it. Okay.
Yeah.
Brandon, thank you so much again. This has really been a fantastic presentation, and I'm glad you brought your books up. I meant to mention that at the beginning, and I forgot. But I do want to say to everybody who's still here, if you like this presentation and you want to find out about others that the Cleveland chapter does, and we do a lot, shoot me an email. We actually have a link to our contact list, but I don't have it handy. So you can feel free to just send me an email at petergeller.lac@gmail, and I will be in touch with you about how to get on the list. And then because we do a monthly newsletter pretty much, mostly monthly, about our upcoming events. And we do have one in just a couple of weeks, May 6th, on an integrative pharmacology topic, which we haven't done before. So that's all that I'm going to say. And oh, yes, Jess, thank you. Happy Earth Day. I wanted to say that at the beginning, too. Yeah, very appropriate that you spoke today, I think.
Thank you. I appreciate you listening in, and appreciate you too, Peter, for hosting me.
Oh, for sure. Thank you. Thank you for connecting with me.
Yeah.
I saw a flash through the screen that said was my email, and I didn't catch what you wrote down, but it's petergeller.lac@gmail. If you want to get in touch. Okay. Jess and Brandon, yes, that's it. No capital P, just lowercase p. Thank you so much
It
again.
automatically capitalizes it, but it'll get the same link.
Oh,
Thanks so
okay.
much. I really appreciated this. Everyone have a wonderful evening. I'm going to stop it, okay?
Yeah.
Okay, all right.
Good night.
Bye. Thank you.
Thank you.